Take a look at this large-bore medical trocar. Instruments like this are designed to pass through layers of muscle and tissue to reach the retroperitoneum. The primary objective of a percutaneous nephrostomy is to create a safe, artificial tract from the outside of the skin directly into the internal collecting system of the kidney. Attempting this blindly, or by passing a needle straight through the dense renal parenchyma, immediately exposes the patient to lethal consequences. A direct stick significantly raises the risk of massive urine leaks or catastrophic internal bleeding. The native kidneys process an immense volume of blood. Puncturing the wrong section of this highly vascular tissue can trigger sudden hemorrhage that is incredibly difficult to control from the outside. And the external anatomy is equally hostile. Misjudging the entry vector by just a few degrees can result in a pneumothorax by piercing the lung cavity, or it can cause lethal sepsis by perforating the adjacent colon. Securing percutaneous access relies entirely on exact three-dimensional spatial mapping. It is a strict geometric puzzle where tactile feedback is useless and millimeter precision is required to survive the procedure. This transverse diagram maps the top-down physical layout of the kidneys alongside the colon, liver, spleen, and paraspinal muscles. Revealing the dense arterial tree inside, we observe the critical vascular layout. Notice the distinct gap between the anterior and posterior branches. That gap is Brodal's avascular zone. To secure safe percutaneous access, the physician must thread the needle directly through this specific corridor to avoid severing major arteries. Hitting Brodal's avascular zone requires a precise entry trajectory of exactly 30 degrees off the sagittal plane, angling posterolaterally from the back. The puncture must occur 10 centimeters or less lateral to the spinal midline. Violating this 10 centimeter limit forces geometric failure. Drifting too far medially requires the physician to force large, blunt dilators through thick paraspinal muscles. Drifting too far laterally pushes the trajectory directly into the colon. Along with the correct entry vector, the needle needs the correct internal destination. The ideal target is the lower pole of a posteriorly oriented calyx. This specific location creates a straighter, less angled approach for threading the guide wire into the system. Targeting the lower pole provides a critical benefit. By keeping the needle low on the geometry, the physician actively keeps the trajectory out of the upper chest cavity, minimizing the chance of inducing a pneumothorax. This split-screen diagram compares the native 30-degree posterolateral approach against a pelvic transplant kidney. Because transplants sit lower, the target completely reverses. Access requires an anterolateral approach toward the middle or upper pole, avoiding the peritoneum. Preventing iatrogenic trauma requires absolute adherence to these specific degree angles, centimeter boundaries, and polar targets before the needle ever touches the skin. Once mapped, the internal collecting system's physical volume dictates the specific technique used to enter it. The system will be hydronephrotic, meaning it is dilated with backed-up urine, or completely collapsed. This diagram demonstrates the single-stick protocol for grossly dilated systems. An ultrasound beam guides a single needle straight into the expanded lower posterior pole. The tract is then widened under fluoroscopy to accommodate a guide wire, allowing a drainage tube to lock into the space. A non-dilated, collapsed system presents a high-difficulty scenario. The target is effectively flat, requiring a multi-stage process known as the double-stick protocol. In a collapsed system, the double stick begins. A needle enters any viable kidney location to access the architecture. Air is injected, rising to expand the posterior calyces. A second needle then precisely targets this newly air-filled space to establish the permanent tract. Managing the internal fluid volume dictates the entire mechanical approach, turning what is normally a simple one-step alignment into a complex two-step geometric construction. Initial access establishes external drainage into a bag, but the ultimate procedural goal is a nephroureteral stent, commonly called a double J stent. This converts the temporary external drain into a permanent internal diversion. Deploying a double J stent carries a strict anatomical prerequisite. The patient must possess a fully functioning, non-obstructed bladder, capable of voiding urine naturally. If the patient suffers from an outlet obstruction, neurogenic bladder, or massive pelvic tumors, Diverting urine down into a bladder that cannot empty defeats the entire purpose of the procedure. When the bladder is functional, physicians execute a staged mechanical transition, known as the safety protocol, to deploy the internal stent. This diagram outlines the safety protocol setup: an internal double J stent, running from kidney to bladder, deployed alongside a parallel percutaneous nephrostomy tube exiting the back. The external tube is then physically capped, forcing all urine flow down the internal stent. The patient then enters a mandatory 24 to 48-hour observation window. This tests if the internal biological system can handle the hydraulic pressure of the diverted urine. To confirm unobstructed downward flow, the physician performs an antegrade nephrostogram, injecting contrast dye down the tube. If flow is completely clear, the external safety tube is pulled entirely. If obstructed, the cap is simply removed to instantly restore external drainage. The safety protocol prevents the catastrophic loss of the surgical tract. It ensures a mechanical fallback exists the moment the internal biology rejects the diversion. Even with perfect mapping, procedures fail. This bright red fluid rapidly filling a drainage tube signals the most severe complication: acute arterial hemorrhage. This creates a deceptive, highly dangerous clinical scenario. The patient's blood pressure drops rapidly, and the external tube is filling with frank blood. Yet an emergent angiogram scanning the arteries shows absolutely no active bleeding source. This cross-section diagram illustrates the mechanical trap causing the discrepancy. The newly placed thick catheter is physically pressing directly against a torn segmental artery. It acts as a tamponade, temporarily crushing the vessel and hiding the active hemorrhage from the imaging equipment. To unmask the bleeder, the physician must pull the catheter completely out, but this requires strict mechanical discipline. The catheter is removed over a guide wire. As the wire is threaded and the tube slides out, the torn artery instantly hemorrhages. Retaining that guide wire access is absolutely non-negotiable. Without the wire marking the exact physical tract into the kidney, the physician loses access entirely and has no way to return to the site of the trauma. With the wire in place and the bleed unmasked, the physician reshoots the angiogram to locate the active spurt. They then thread a new catheter over that exact same wire to perform highly selective embolization, deploying coils to permanently block the bleeding vessel. Interventional mastery requires exact spatial geometry. When that geometry violently fails, survival depends entirely on strict mechanical discipline to retain control of the anatomy.